Hey everyone, welcome to tonight's Grand Round session. We definitely have a little bit of a different format for our topic tonight, but something that's definitely very relevant to all of our practices, and that will be cost. And it is my honor to introduce our moderator of the evening, Dr. Ori Weisel. Very, very happy to have you here and appreciate that you're able to join us from Israel because it's definitely later there than it is here in the States. Dr. Weisel is a clinical associate professor of surgery at Bar-Ilan University and the director of thoracic and esophageal surgery at Safan Medical Center. He is also a SSAT board member, as well as a member of the JOGS editorial board. So very, very active in SSAT. And he will introduce our speaker tonight.
Uh, Happy to be here. Thank you for the invitation. So tonight I'm very glad to attend this SAT complex round about cost of robotic-assisted minimally invasive esophagectomy, and I'm very looking forward to hear Dr. Hilva and Dr. Awad's presentation from the University of Florida Health. Some housekeeping rules before we shoot the topic. And we'll follow with a good presentation, and the topic will presented as we heard from Dr. Tilva, and followed by Dr. Zawad, the comments if they wish. Please keep your microphone closed during the presentation, and you can ask question either by the chat or ask during the presentation itself. Raise your hand, and we'll follow and monitor that. And I think before going into details, I think that today's topic is fascinating by the fact that although we are all driven by providing excellent patient care, we all know that this kind of care costs money. And as technology progresses, there is still this fine line that all of us follow between better outcomes and shorter hospital care, stay, for example, less invasive procedures. But this comes with significant cost. Where this fine line stands between moving along with progress and technology, the technology is cost effective in certain types of procedure, and in which, for example, should we uh, keep this technology doing 5 robotic small cases that the patient goes home within 1 or 2 days, or should we keep it to a major surgeries like we do in esophagectomy, one major case and the patient stays in house for a week with a large implication profile, or is it vice versa? So all these questions are really important, and I hope that today we can learn more from this fascinating talk from the University of Florida Health, and followed by the discussion. So I urge you to prepare questions, and I would like to specifically hear there are some international surgeons that will give us their input about the systems in their country. I can present Israel and other places which I've been. So without further ado, I turn the stage to our presenter.
All right, thank you so much, Dr. Riesel. Good afternoon, everyone. Good evening to you, Dr. Riesel in Israel. Like mentioned, today I'll be presenting on the cost efficiency or cost effectiveness, really, of assisted minimally invasive esophagectomy comparing to totally laparoscopic esophagectomy. I have no um, disclosures, financial disclosures. So let's get started. So these are the learning objectives. I want everyone to kind of be able to define what is the average direct cost and average total cost. These are economic terms, but kind of also define what they mean, because if you Google these, you'll find economics curves from Econ 101 type university courses. But when it comes to healthcare and surgery, what fits under each of these umbrellas? And then define what is this MSDRG, Medicare Severity Diagnosis Related Group. This is relevant to the US, but I'll mention that this similar type of definition and entity is used throughout a lot of healthcare systems throughout Europe. And then explain how this is related to something called the CMI Case Mix Index. And then lastly, kind of conceptualize how a robotic surgery could have a higher total costs, but when you normalize it for certain variables, it could be similar. So the main question, a very loaded question, is how much, right? Someone, how much does a surgery cost? And the first question, thing comes up is, does anybody really know? Especially in the United States, costs are such a hot topic because you hear all these things in the media. Oh, I had my appendix out and I got a $40,000 bill in the mail, and these like nightmare horror stories that put people in medical debt. And so there's this stigma that surgery is extremely expensive, and it is, but I think the public perception as to what the surgeon's making and how much a surgery costs and what it costs the hospital system, they're all very different things. And so when you talk about costs, I think the first thing that comes up is, or you have to say, is it depends. And it depends on what, and it's how you define what something costs. To the different people and players involved, it can be a very different thing. So to a patient, at the end of the day, comes out how much came out of their pocket, what came into their bill in the mail, and how much did they actually have to, pay. Insurance companies just care about what were the charges sent to them, how much could they push off onto the patient, and how much are they having to pay. Hospitals care about very different things. They have to keep the lights on in the hospital. They got to pay the cleaning staff, maintenance, pay for all the equipment. They care. If you're doing CT scans, they got to make sure that there's enough CT scanners, that there's, not a 20-person line, and, the inpatient person's not waiting 10 hours to get a stat CT scan. So they got to start paying more money to have all that, upfront infrastructure. And so for them, things cost differently because they have to pay for expensive equipment, even though the actual unit cost per CT scan could be much cheaper, right? And so everybody who's involved has a different definition, that matters to them as to how much something costs. And so as a surgeon, I think we need to have an idea of what are the meaningful costs to us and things that matter to us. Um, and I think when you're comparing costs between different surgical modalities, if you have an agenda going in, if you have a bias or something that you want to show, I think you can, through clever math and accounting methods, show whatever you want. If you want to show that robotics is more expensive, then just show exactly what the OR time and the instrument times costs, right? But that doesn't tell the whole story, because you're not looking at complications and length of stay and all the different kinds of things. And so whenever somebody says this is more expensive than that, you have to ask quite a few follow-up questions to know how did they define costs, and figure out that you're talking about the same thing. And if they're talking about something else, know what that means and if it's relevant to you or if you buy it. So how much is a very loaded question. And so part of this talk is to figure out how to unload it, or among surgeons and the people, providing the care and doing the surgeries, what common language should we be speaking about cost? So if we're talking about robotic surgery, I think a fair question and a fair place to start is how much, does the robot cost? So, anybody, and, if we're not going to go that interactive. Anybody have any guesses? You can put it in the chat of, how much is the initial capital cost, that a hospital system has to pay for, the latest and greatest Da Vinci robot? And any ballpark answers? Yeah, 1.5. I see 1 million. Yeah, anywhere 1.5, 2 million now with the DV5 is, what's kind of quoted out there in the literature, for this initial capital cost. And then, once the hospital buys the robot, that's not it. They have to pay this yearly service contract. So that friendly, intuitive rep that seems to always be around when you have the case and is checking in and stuff, they're not there because they have, amazing customer service, and they're there out of, because they stand, it's because the hospital is paying them a six-figure yearly service contract, to make sure the robot is properly maintained, that its software is up to date, that there is support, and depending on, whatever plan package, the premium package, whatever it is that the hospital is paying for, it depends on, determines, if there's somebody there on site 24/7 or someone who can be there. And, for some smaller hospitals where, it's a prohibitive upfront capital investment for, $1.5, $2 million robot. The same way you can either buy a car or you can lease a car, there's clever arrangements financially that Intuitive has come up with where it's a per use thing. And so you pay a certain amount, like a down payment, and every time a surgeon uses the robot, there's a fee associated with it. And so there's lots of different ways in which a hospital acquires the robot and different contracts that they have. And so even within that, it's hard to delineate where this capital investment comes into. And then on top of buying the robot, paying every year, even if you did 0 cases each year, you had to pay for the robot and have someone there to service it and, have this service contract. Then every time you use the robot, there's the disposables. And so if anyone had to venture a guess, what makes Da Vinci and Intuitive the most money? Is it selling if you look at their yearly revenue, is it how many robots they sell? Is it the kind of like a Costco membership, that yearly fee, that they make their true profit off of, that service contract, or is it the disposables? If anyone has any guesses in the chat, that'll be great. But yep, yeah, disposables. So up to $3,000. It could be more depending on the case, how many staple loads you use. And then the energy devices are obviously the more expensive of the disposables compared to, just a needle driver versus the vessel sealer, the SynchroSeal, all these new latest and greatest, bipolar energy devices. And if you compare that to laparoscopic instrumentation, it's definitely more. Um, Typically, laparoscopic cases, it's less than $1,000 for the disposables. That would be your ligature, your harmonic, whatever it is, and a stapler with a couple of staple loads. But if you're doing the same surgery robotically, you're opening up a vessel sealer, you got the monopolar scissors, a stapler, it's going to be more expensive. And it's hard to find this information. If you Google it, you're not going to really see it. There's a couple databases that maybe have this information about what the hospitals are actually paying because everybody has a different contract, especially in the United States, with Intuitive or whoever it is, whoever is supplying Ethicon or Medtronic, whoever is supplying the energy devices, the staplers. Everybody's got, their own little contract and how much of a deal they're getting on their staplers. And so you can't really compare these, nationwide. And so that's another difficulty in this is that everything's kind of hidden. And then the last thing is, the length of case that kind of comes up over and over and over again. Oh, the robotic surgery is longer, so you're going to have more anesthesia time, more OR time. And so, and inherently, even if you kept the disposables the same level, it's just going to cost more because you spent more time doing it. And so unless you're really getting a length of stay or an outcome like a complication benefit, you got to first thing the robot has to do, it's already in a hole and it's got to justify the length of the case by making up for it with some sort of length of stay or a complication reduction metric just to become even with laparoscopic surgery, right? And, you hear that all the time for cholecystectomy or, some people are even doing like a or a robotic appendectomy or something like that. And so, that all factors into how much a robot costs. So, kind of going back to what we had initially mentioned, this is the revenue from a 2017 study that looked at US and global revenue, and these are in dollars for robotic surgery. And you could pretty much assume this is all Intuitive, Da Vinci revenue. There's a couple places that have, other company robots, and that might, that's on the forefront. It might disrupt the market. But right now, we can all pretty much operate under the assumption that we're talking about the Intuitive Da Vinci robot. And so, $2.2 billion gross revenue in the US in 2017. And so that's now, I don't even want to think about it, but that's almost, 9, 10 years ago. And global revenue 3 billion. And if you look, almost a billion of that almost is just from selling the robot, right? The 1.5 to whatever $1 million every time they sell the robot. But the disposables is what's making them money. And if you can assume that's what's making them money, that's also what's driving our costs as a healthcare system. The service contract is there, but it's the instrumentation, it's that 10 uses, and now the scissors are all of a sudden no longer safe or good to use. And so, you got to open up a new pack. And so that's what's driving their revenue. And that is also what's driving the cost per surgery. Um, and part of what factors into that is, the challenge of defining these costs. And so there's robotic systems get, the same way, if you may have heard this term amortization of a capital cost, and, in terms of mortgages or something like that. And it basically comes down to how long do you say that the upfront payment of the robot is being divided over. And so different hospital systems will amortize that cost of the robot, whether it's the robot or when they buy a new MRI machine or a new CT scanner, over a certain number of years. And kind of the standard is around 10 years, but not every hospital system is going to, account for things the same way. They all have different agendas and different ways of doing things. And so they basically take the cost, that capital cost of the robot, $2 million or whatever it is, and divide it by 10 years and say, okay, after 10 years, we've paid, a tenth of it over 10 years. And after that, now we've like paid the robot off. And so we're no longer going to be like including that into our like per surgery costs. But up until then, it is like every time you use it, it's like a tenth of, the cost over those 10 years gets like factored into it. I think the same thing probably happened with laparoscopic surgery when the hospitals all had to like, okay, now we got to renovate all our ORs. We got to put lap towers in or integrate monitors into all the ORs. And so when you're talking about robotic surgery, no one's saying like, oh yeah, but this OR needs to be renovated because it needed 3 monitors for for this and that for laparoscopic surgery. And so nobody really mentions that anymore because it's kind of a given now, right? And those costs have been eaten. The hospital system's paid for them. It's been long enough time that they're no longer in like the yearly accounting and quarterly accounting reports. And so with the robot, it kind of goes the same way. If a hospital system bought a Da Vinci Xi like 10 years ago and it's kind of paid off now, they're kind of like, okay, we've paid it off and now let's use it as much as we can. Whereas a system that hasn't gotten into robotics yet now has to like, upfront $2 million for the new DV5. It's a very different conversation that's probably happening within their leadership about costs and utilization and all that type of stuff. And so, if it hasn't been kind of evident already, there's a lot of challenges in defining healthcare costs. Every system's using different terminology. The terminology is being used interchangeably. There are things that are called direct costs, indirect costs, fixed costs, variable costs. These are all things that accountants and economics people have very specific definitions and ideas of, and whether or not the healthcare system is applying them and using those definitions, the same way is not always clear. And specifically within the US, you have to then think about all the hospital systems aren't getting their money the same way. Some places are nonprofit places, and so they might be writing certain costs off in certain ways for accounting purposes to show that they're a nonprofit system. Others aren't, and so it's just a very messy, zone to be in when you're talking about cost. And so as the surgical side and the clinicians and the people actually doing the surgery, what is the right metric and cost definitions that we should be using when specifically we just want to compare robotic versus laparoscopic? What costs more overall? And so I would argue that we should be using these two definitions. The first is something called the average direct cost. And this is a well-established economics term, average direct cost, when you look at, Econ 101 and they're studying, factory and somebody's supply and demand and all that stuff. This is a well-established definition, and it's cost directly attributable to production of one unit of something. And so when you apply it to healthcare, it's cost directly attributable to the patient's care. So it's the OR time, the supplies, the medications, the cost of getting the CAT scan, running the labs, getting that daily CBC, the chest X-ray, all that stuff applies into the average direct cost for a hospitalization associated with an index operation, in this case, esophagectomy. Whereas the average total cost takes the average direct cost or the direct cost, and then you add in the overhead, all the administrative expenses, keeping the lights on, keeping the hallways clean, all of that stuff, as well as all the overhead, right? And so the average total cost for a certain hospital system may be going up because they've now spent a certain amount of money to renovate all their ORs. And so, depending on how they amortize that capital cost, the same way that they would amortize expending money on a robot, is going to increase their average total cost over a certain amount of time in which how long they amortize it, right? 10 years or something like that. And so comparing the average total cost is a little bit trickier because you don't know how a facility is doing in terms of its administrative expenses, all its overhead expenses, all those capital costs, the robot, when they bought the robot, if they just bought it, it's already paid for, right? And so I think average direct cost is probably the best variable to use when you're comparing surgical techniques because it's going to include, one surgery has a twice as long length of stay. Well, then you're going to have longer hospital charges, nursing charges, and if someone stays twice as long, you're going to assume they, get labs drawn more frequently, whatever it is. All those costs go into this average direct cost until they're discharged. And so I think that's where we really need to be looking. But the average total cost is something we can't ignore because, as a new technology, kind of relatively new now, but with more systems adopting robotics, where this capital cost of the robot comes into, and people saying, yeah, but the hospital has to pay for it, and then they have to kind of it has to pay for itself over a certain number of years. So you can't ignore that. And so that's kind of where the robot fits in, is into the average total cost with the initial investment. And then it fits into the average direct cost, I think, in two areas, the OR time and the instrument cost, and having to open up, all the various devices and stuff for the robot, and if they cost more than laparoscopic. So the robot increases both of these costs in two ways, or in three ways: OR time, the disposables, and then the capital cost. And so, you can talk about robotics costs, but you have to look at it per procedure, right? We're not using the robot just for we're not doing diagnostic roboscopies. We're doing like diagnostic laparoscopy, right? We're not just like docking the robot just to take a look around and then undock it to see what's going on. We're doing it for specific surgery. And so for robotic-assisted minimally invasive esophagectomy, is anyone looking at the cost for this specifically? And I would say no. Um, Most of the existing studies are really comparing perioperative outcomes, complications, length of stay, oncologic metrics, lymph node harvest, R0 resection rates. Um, and there's kind of the most up-to-date kind of data. A June 2025 meta-analysis looked at about six RCTs and 16 non-RCT studies, and kind of the consensus is there's pretty much equivalent perioperative outcomes and complications in terms of like leaks and those kinds of things. Maybe slightly less length of stay, slightly less transfusion rate, slightly increased R0 resection and lymph node harvest. But overall, the outcomes in terms of the things that really matter, like leak, and major complications are about the same. But nobody's really looking at cost. They've surrogates for cost would be operative time, and it's for sure about 60 minutes or so more operative time for robotic esophagectomy, and that's among 6 RCTs through a meta-analysis. And so, yeah, the OR time is longer. But then everyone says, like, yeah, but if you look at my study, there was fewer transfusions, 2 days less length of stay, or whatever it is. And so then people kind of have a tally board and they say, well, there's one tick for this on this side, one tick for this, let's cancel those out. Or if I've got two positives for the robot and one negative for the robot, it's a net positive for the robot, and so it's like worth it. But no one has specifically looked at what I think is the best metric to look at, which is the average direct cost. And then the trouble also becomes, what do you do when you're not just looking at the United States, you're looking at Europe, at Israel, and other healthcare systems that have all this data. How do you kind of compare these things when the accounting and the healthcare systems are, it's just so different when it comes to cost. So, how
Just to
can we
pause you for a
study
second, there's
this?
a
Yeah.
question in the chat by Dr. Jairaj. I think is the article that you're referencing. Were they all transhiatals, Ivor Lewis? Um,
Yeah, so my question for you is, does it matter if you've got a hybrid approach, meaning, redocking for thoracic versus transhiatal, for example? We tend to favor transhiatal esophagectomy. And I think Dr. Benzi knows by working with us, I think that the lack of changing positioning, those type of things really makes a difference in OR time. But just wondered what you saw when you looked at this. And if it was broken down.
Yeah, so within the individual studies, it's different, and so they did not exclude if it was transhiatal or Ivor Lewis or anything in particular. And so, what's considered a robotically assisted, esophagectomy if the any kind if the if it's a Ivor Lewis, then both the chest and the abdominal portion have to be done robotically. Whereas if it's a transhiatal with a neck anastomosis, then obviously there's only one part involving, the abdomen up through the mediastinum, and that has to be done robotically. And so they were kind of all lumped into one, so to speak. And so I think that is a very important point, because I think one of the conclusions that I'll get to, towards the end of the talk, is that what this information has kind of given to us and looking at our clinical outcomes and stuff is that a hybrid approach probably makes the most sense, using the robot for its strengths and not using it when you don't need to use it. Um, uh, uh, then it probably makes the most sense in terms of cost efficiency. And so, like Dr. Watt's saying in the chart, we're doing Ivor Lewis all the way, as far as all the patient data that I'll present is for Ivor Lewis esophagectomies. And we defined it as doing the abdominal and the chest portion both robotically, is what's considered a robotically assisted esophagectomy. And we excluded ones where the abdomen was done robotically and the chest was done thoracoscopically, as a hybrid approach. And I think once we kind of figure out what's going on with just pure robot versus pure lap, cost comparison and outcomes comparison, the next phase of that research will be looking at these hybrid approaches and if we can kind of optimize it by using the robot where it shines, so to speak. And so, we by and large aren't doing any, transhiatal. And so I can't speak to that. But in terms of what was included in this most recent meta-analysis that I was kind of mentioning, just to get kind of general um, state of the field information, was a mix. But the majority of the studies were a Ivor Lewis approach.
Dr. Silva, I will use this pause and this question as well to add. You were able to parse out from the studies those, you said you added that 1 hour more on the robotic case versus the laparoscopic case or the minimal invasive case. Were there any data about cost for teaching? Sometimes fellows teaching and where learning curve of surgeons takes time and where the cost stands on this point.
Yeah, I think training is a factor into this. And I know this was, brought up kind of over the weekend reviewing these slides. I don't think anybody has specifically looked at the effect of trainees on the operative time specifically to robotics, especially in esophagectomies. I think it's something that we could do because we're going to all have that Da Vinci app data that shows your consult time and kind of compare. But yeah, none of these studies were nuanced enough to kind of present that factor or have enough of delineation in their sampling and to say that like, yeah, if we eliminate the cases where a trainee was involved in, this is what the OR time is versus when a trainee was not involved. But I think that is a factor. I think these surgeries are by and large being done at academic centers where trainees are involved. And so I don't know um, if that'll ever kind of go away or if it's just a factor that's just inherent to this type of surgery. It's a complex surgery done at a tertiary academic type center. And so you can kind of assume for the most part trainees are going to be involved in some aspect.
Thank you.
All right. So kind of coming down to where do we get this cost data from? The hospital is not going to really easily be able to tell you where the money is and where the data is. And so there's a lot of third-party companies that are involved and that hospitals employ and pay for services to kind of data mine out of Epic and look at all their information and kind of find this information out. And when they give you this information, I think the real question that every surgeon is trying to answer is how do you control for patient complexity? And how do you know if a difference in the average direct cost and the average total cost, if you do see one between two methods, is attributable to the surgical approach and not all of the other million confounding variables that can be there. To study this, I think I'm sure some of you are quite familiar with this, but maybe not all. There's this thing called what's called the MSDRG, and kind of derived from that the case mix index. And the MSDRG is what's called Medicare Severity Diagnosis Related Group, and CMI is the case mix index. And so this is a little boring, but really, the MSDRG is this classification system that groups all inpatient stays into categories, and it came due to figuring out how much should Medicare be reimbursing for a certain hospitalization. And they found ways of saying if somebody has a certain primary diagnosis code, and this is why the ICD codes and all that matters so much in your notes and everything that you put into your EMR when you're writing your notes and saying what procedure happened is because they can kind of organize and they can kind of group people into what's a similar code, and they looked at what is their resource consumption and how much should we be reimbursing for this. And then once we've figured out where the average lies for a certain diagnosis, then we can figure out what surgeons, what hospital groups, what hospitals are outliers above the average, below the average. If certain people are constantly below the average, then they deserve some kind of quality or cost savings kickback type thing. And so it's a very useful tool. And, with this being the largest payer source, it's a very powerful group. And so when they kind of came up with this, everyone followed suit. And so patients are assigned these 770 so far in the US diagnosis groups, and it has like what's the principal diagnosis, what's the secondary diagnosis, what are all the surgeries and procedures that were performed during that hospitalization for a certain diagnosis, age, gender, where if they went home versus to a nursing home, to acute rehab, subacute rehab, or if they died and they weren't, discharged to a certain specific location. All that affects this MSDRG. And for example, the US, we're using roughly 770 of these categorizations. Just for comparison, a very similar system was developed and used in Germany, and they're using over 2,600 of these things. And so the different hospital systems, it's used, a version of this is used in the NHS in England, it's used in the Netherlands, used in Germany. And so it's not unique to the US. This philosophy or what the concept of this is used through many healthcare systems. And we kind of don't have the best version of it because of all our various insurance payers and factors in the system. And then the severity level, oh, sorry, is based off of these secondary diagnosis codes. And it's if somebody has a major complication or a comorbidity, and that's like a highest severity, complications and comorbidities. And it is a mathematical model which assigns weights to each of these. And a weight of 1.0 basically means this is average resource consumption of all patients. So if you took all the patients in the United States and the model spits out that the average MSDRG should be 1. And so you know that if you look at the MSDRG for your subset of patients, if it's over 1, then you know you're dealing with patients that are kind of, in general, more complex than the average patient. Right? And so it's a normalized weighted system. And what the case mix index is it takes those MSDRGs and it's the average of the relative weights, and you kind of divide it by the total number of discharges. So really where the case mix index and the MSDRG vary is based off of the mortality rate. And so if there are more deaths and patients they aren't technically discharged, then it's going to raise your case mix index compared to what the MSDRG. But in a lot of cases, the case mix index and the MSDRG, when you look at the actual numbers, are pretty much the same.
Dr. Benzi, I hope you don't mind me jumping in over here because I think this is a really good learning chance for our fellows because you actually want to make your cases look like they're the sickest patients and have the highest expected mortality. Just from a medical staff and a sort of from an outcomes-based standpoint, and Dr. Weasel, if you could maybe, discuss that a little bit, you don't want to seem like you're having a mortality of, 0.5% and your actual mortality is 1%. You actually want to document your comorbidities well and accurately. I mean, don't make up stuff, but do it accurately. What are your thoughts, Dr. Weasel?
Yeah, I think the whole presentation speaks about, cost, benefit per cost. I mean, what should we try to introduce technology that costs money, and by the end of the day, as the participants said, the question is, should we take it at the average direct or the average total? And how can we increase our revenue from the surgeries, from the payers, by what you exactly said, Juan, about, increase the acuity of the case, and by the end of the day, get more from the insurers, rather than lose from the case. So that's a fine line that we should figure out. But I totally agree that by the end of the day, documentation is for us. I mean, if we'll document the sickest patient by the sickest patient, then we'll be able to, at least in the US, to deal more, or I guess you lower the amount expenses of the surgery if you're not extending by the case mix index, and which is different for example, in my country. I can document as much diagnosis for the patient, as sick is the patient, By the end of the day, no one cares. There is the X amount of money that the hospital will get for the case, regardless if it's an open surgery, a minimal invasive laparoscopic or laparoscopic, hybrid, or robotic. No one cares if the patient stays for 1 week because he has a perfect post-op, or he stays for 1 month. The hospital gets the cost for that. So it doesn't. Israel is, for example, different than the US, and we bill according to the case mix index and what you discussed there. So it's an excellent point, but it's different among places. So in the US, it's very important to your point to document very well.
Yeah, no, thank you very much. And just for you to know, Dr. Tilva, in the HBB side, which, obviously I do a lot of, the three DRG codes, 405, 406, 407, we actually have a measure to look at all of the 407s, because actually none of the patients should fall into that group because none of them have no comorbidities. So, and that, just for the trainees on the call to understand, the hospital really appreciates you working with them on things like this. Dr. Awad, one of the things that has changed is there's this new DRG code for MIS esophagectomy. Has that made a difference for you? Because, before we were using a unlisted code for these esophageal cases, 43289, I think is what it is. And has that changed things for you? I'm in sort of a private practice model, so we get to really have to look at these very specific and granular things. What are your thoughts, Dr. Awad?
Um, Thank you for the question, Rohan. I am not quite sure if this changed anything, just laparoscopic or open. I know for a fact that the esophagectomy, it's broken down to many CPT codes in our practice. One is the Ivor-Lewis esophagectomy. Number two is the spine angiography. Three, a method lab, mediastinal lymph node dissection, uh, abdominal regional lymph node dissection of the jejunostomy tube. So these are the codes are built into our Epic esophagectomy. But I don't know there's a difference between open and
So
laparoscopic.
that's actually amazing because I always get bumped back that the nodal dissection, even if it's out of the usual nodal dissection, they say that it's bundled. And so I'd love to see what your billers say at the end of the day, but that's a discussion for another time. But
Sure.
thank you for that.
I can tell you right off the bat that the RVUs for esophagectomy at our place is 150.
Wow,
Yeah.
that's
So
amazing.
yeah, so the esophagectomy by itself, Ivor Lewis or transhiatal is 70, 75. Then you add all these extra CPT codes documented, then it's 150.
Wow. I need
Yeah,
to come work there. Dr. Bentley, we're in the wrong places.
there we go.
Thank you.
Thank you.
Yeah, so I think to your point that the hospitals are paying attention to what their case mix index is and what their MSDRG is because, like you said, you want to make sure that you're fairly capturing how sick your patient population is, so that you're being fairly judged for your outcomes and how much it's costing you to take care of your patients. And so, just for example, in University of Florida, there's a dot phrase that everyone keeps harping on about in the pre-op H&P that forces you to go and check all the pre-op labs, document every single abnormality and diagnosis that's going on with the patient, so that it's documented in a place that's easy for the coders and the people that put the data into Epic, where then it's then taken out of to see because you might know, oh yeah, this person's real sick, but unless it shows up somewhere in their Epic H&P and in somewhere where then the coders can go and find that information, it's not showing up in their MSDRG. And if your case mix index is artificially low because you're just not capturing this information accurately, then when it's costing you more to take care of these patients than the average, then someone's, then calling you to a meeting to discuss what's going on, and then you're trying to then like justify without actually having the data there. And so this is where it's tedious, but accurately documenting the condition and the severity of the comorbidities of your patients makes a big difference, because this is how you're being judged. So you might as well code it to specifically, explain to the people who are judging you how you're being judged for these costs and what's going on. Um, all right, so this was kind of, yeah, we've gone through the questions and discussion a little bit for this first phase. So unless there's any other burning questions or points, I will go on to the next phase, which is what did we look at? So from January 2021 to June 2024, we looked at all of the adult patients undergoing a robotic or laparoscopic esophagectomy for esophageal cancer. We had 206 patients. Anyone who underwent hybrid, so either the chest or the belly portion was done open, or like the chest was done thoracoscopically and the belly was done robotically, those were excluded. And so it was either everything was done laparoscopic or everything was done robotically. And then obviously we did an intention to treat. So if there was a conversion to open, that was included. So we weren't, excluding those cases that way. If one technique had a higher conversion to open rate, which would then include increased costs of having to open all the open instruments, longer OR time, complications, whatever it is, that got included. So we weren't skipping those. And that's who we looked at. So 206 patients, basic demographics, there was no difference between the groups. Where it really comes down to, the important things, these are unadjusted costs, and the two variables that I mentioned before, average total cost, average direct cost, statistically significantly higher for the robotic group, basically double for robotic for total and direct costs compared to the laparoscopic group. And these are the dollar figures. Um, um, but like I said, how do we know if these difference in costs are due to the surgical technique or due to the patient population and all the other factors that go into it? And so we look at the case mix index and that MSDRG score, and it's significantly higher for the robotic group, 5.5 to 2.8, 5 to 2.8. 2.28 for the laparoscopic group. And so when you normalize to the case mix index, which would be risk adjusting these costs, that discrepancy goes away completely. It's almost the costs for total and direct costs are basically the same when you account for the case mix index and the MSDR for the two patient populations for these methods. And so that was pretty astounding to us. And then we looked at something called the direct cost index. And so for Ramey and minimally invasive laparoscopic, they were both less than one. And so what the direct cost index does is Vizient, they get all this data, not just from us, but from all of their other customers. And so they were able to compare our institution in the blue line, the study institution, over from 2021 to 2024, and compare our costs to other large specialized complex medical centers, as well as safety net hospitals, large volume safety net hospitals, and found that our direct cost index was less than one for the robotic. This is for the robotic data. And so, what looking at your direct cost index does is it tells you if is your direct cost just higher because you're using the robot inefficiently, whether it's you're using too many instruments, taking too long to use it, everything that goes into that direct cost. If you were higher than one, that kind of indicates that you're an outlier with respect to the other institutions who are doing a similar thing with the same tool. And so keeping a direct cost index one or less means that you know that the increase in costs seen, average direct costs seen for robotics, isn't because, to kind of put it bluntly, you suck at using the robot, is what this metric shows. And it shows that, yeah, you know what you're doing. You're using it in the same way everyone else is using it. You're not using it any more inefficiently, or there isn't something that's happening when you use the robot. And so I think this is an important metric that people should be showing if they show their costs, is this cost index compared to peers, because I think it eliminates that large confounding variable, which is like, if all of a sudden our cost index was much higher, then we would have to look into is it because, as was kind of mentioned before, a lot of trainees are involved and fellows are doing 95% of the case and it's just taking a lot longer. That's where that would show up in the direct cost index. And so kind of an indirect way of addressing that concern of having trainees involved in these cases would be to direct cost index for both robotic and laparoscopic surgeries, because you would assume that the effect of trainees is ubiquitous, and so whether they're involved in robotics or laparoscopic surgery, if you're below one, then you're not doing something abnormal. And then one thing to look at is obviously the complication rate. And so it was a 20 versus 11%, non-statistically significant complication rate in robotic versus laparoscopic. And this is Vizient tract complications. And so they use this composite complication metric, involved all these things: aspiration, shock, stroke or NMI, infection, readmission, GI hemorrhage, C. diff, leak, reoperation. And this is all based off of the ICD diagnosis codes. And so, we have to take this information with a grain of salt, because when I compared this to, doing some chart review into these, 17 and 13 cases on each side, it didn't really line up with what we would track as complications in our, prospectively maintained database of our esophagectomy patients. And part of that has to be like an intraoperative complication that Vizient somehow tracks, is that like a trocar gets placed and it like nicks the liver or something, and it considers that as like a liver hemorrhage complication or something like that, where clinically it's like, okay, it may have touched that, and somehow they like pick that up from the op note. And so they're mining this data, the coders are. And so unless you're like going and chart checking and chart reviewing every single one of these patients, there's going to be over and under capture of the complications, things like post-operative, like hemorrhage or something requiring transfusions, depending on the way. Sometimes an intern or a junior resident in the ICU words their note and puts, into the note, the coders bill for one thing versus another. Somebody had some blood in their stool versus like someone needed a transfusion, and then get one of these coding queries in Epic, like, oh, was this a complication, or was this considered post-op hemorrhage? Yes or no? All those things play into the fact they ask those questions, because the way they code those is how, somebody like Vizient will find these ICD codes. And so overall, based off of their information, there was a similar complication rate between the two groups. But when we look specifically at our prospectively tracked database, some of these could disappear.
Can I ask one question just to hold here? I mean, obviously, aspiration pneumonia is different in terms of length of stay of an osmotic leak. Was this transparent on the data that you collected, and because the cost of this obviously will change. So this was lumped as one complication basket. Everything is the complication, zero or none, or did you check it, according to the complication? Because that matters. I mean, obviously, anastomotic leak is more significant than aspiration pneumonia or just pneumonia.
Yeah, I agree. So yeah, this was an all or none type composite complication complication metric. And so, like you said, depending on what it is, makes a big difference in the length of stay and the overall hospitalization cost. And so, personally, look into like, oh, were there certain outliers or patients who stayed for a really long time because one thing leads to another, and then they have this like prolonged saga of a hospitalization, and then is that what's driving their cost? But those types of patients, I think, exist in both groups. And so, so you can't, it's as much as it's sometimes you want to, you can't go cherry picking out those like cases that stick in your head and you remember, oh yeah, this guy had like a crazy course. Like obviously he's not like the standard, we can't include him. And so I think we just included everybody and assume that that type of outlier gets evened out in the data.
To your point, I mean, liver hemorrhage is different than true liver hemorrhage that affect length
Yeah.
of stay is different than a small nit in the liver from grasping or from a trocar. I see Dr. Awad's comment about the language is different from clinical practice, so this is obviously the problem with those large databases.
Yeah. And I think it's an interesting point or a key point is that, the people that are making the decisions about whether things are cost effective or using things efficiently are speaking a different language than we are when we're looking at clinically what's going on. And so, sometimes we gotta be sitting in the same room and explain to them that like, yeah, just because your database and, the way you mined all this data is saying, saying this, you have to run it by us because we have to be able to speak both languages to be able to tell them if the signals that they're getting are useful or not. And I think we have to kind of take ownership at the end of the day about the costs of the technology that we're using and know when what we're doing is just like unnecessarily expensive versus there is a benefit or we're not sure yet and we need more information to find out. But we can't let people who don't know the clinical picture, who can't tell the difference between like, an extracted diagnosis code and actually like read the chart or took care of the patient to know if something was like actually a complication or actually like made a clinical difference. And so I think this is where, as much as people hate to talk about costs, we have to take ownership of it because unless we do, we're going to get then told what we can and can't do or what we can and can't use, um, you know, to do
I
our
think
studies.
that's a great conclusion for your paper. Just put on the line that those people who count the numbers are not the clinicians.
Yeah. Before you make a change, please run it by me is like the final conclusion. And so this is just another one of those Vizian track, informations is a length of stay index, pretty much the same, slightly lower for the robotic group as a trend. Um, and I recognize almost 6 o'clock, so we'll just keep going here. And then this is average direct cost per case. It's hard to really tell. It kind of went up in 2022, but then they all started to slightly come down, whether it was robotic versus laparoscopically. Not gonna. I don't know. I don't know who the fellow was in 2022. Maybe we need to look at the operative times for then or something. Hopefully 2025 is a good time. We haven't gotten there yet. And then just to kind of show, some of the fellows, like what I'm talking about, like these Vizient guys or whoever it is, whatever third party you're running through that is giving you this information, this is what they're getting out. And so if I just show you, this is like an Excel file of just columns upon columns of diagnosis codes for these same patients. And they're not reading every single one of these. And if you have to like literally go through each one of these, look in the chart, or like Dr. Awad does, collect this kind of prospective database of the complications to then be able to tell like, okay, they tracked all these complications, but when we look at our actual data, you know, okay, half of these were garbage or not garbage, right? And so um, that's just what we're dealing with, but the reality is this kind of Excel file data dump and the conclusions that get drawn from it from these third parties is what gets presented to some CFO or CEO on their desk at some quarterly meeting, and they get told, okay, what's the bottom line of all this data you're showing me? And someone's going to tell them, oh yeah, the robot is costing us way too much money, you need to fix that. And then we get told stuff about our surgeries without people who actually know what's going on. And so my conclusions, yeah, robotics has a higher actual cost at our institution, but when you compare our cost efficiency or our direct cost index, we're the same as other institutions, so we're not using it inefficiently. And when you account for the patient severity, it kind of goes away. And so hybrid operations is kind of the way we've actually changed our clinical practice recently, I would say in the last year, to talk about using the robot for specific parts of the surgery. So, just to, be clear with you, we'll make the conduit laparoscopically where we can, affect, how much we're putting pressure on the conduit and grasping it or not touching it. But then when it comes to like the lymph node dissection, we'll use the robot. And then we've been going back and forth between using the robot or just doing it laparoscopically for the chest dissection. And so I think the next phase of this study and our evaluation of our costs will be the hybrid approach, and see where that takes us. So I think that's all I have. Thank you all for your attention and your comments and everything. Hope to answer any questions or have a great discussion.
I need to have a few minutes for questions and discussion, or
Dr. Evis just had a comment as well. If you wanted to
yes.
chime in. Thumbs up to hybrid. Yeah.
Yeah, no, I think, what I was saying is that I like to be the optimist here and think that the reason that after risk adjustment, the cost kind of fell out is because assuming that the surgeons involved in this study were equally comfortable with laparoscopy and robotics, that they used the robot when they needed the extra wristed instrumentation and the 3D view and the magnification, et cetera. And then those cases that were doable with laparoscopy were done with laparoscopy, and therefore the costs are lower, but also the complexity and difficulty level may have been lower. I mean, there's a lot of variables that's hard to tease out and such. But rather than saying robots great, laparoscopy stinks, or vice versa, it looks like, and I absolutely agree, that hybridized approach, meaning we're going to use the robot for where we need the robot, and we'll do laparoscopy where the laparoscopy is sufficient, is a good, I think, utilization of resources. So excited about the next phase of your outcomes and your research.
Found you, I mean, the opposite. I mean, either you, I mean, specifically, not just in the US, but either you do it all your cases robotically, then you justify the use for the robot. I mean, it's very tough to tease out which case you should do robotically or not robotically. Obviously, hybrid is great. I mean, you can do a gastrectomy with the D2 dissection with the robot, but there will be surgeon in the East that will tell you why they don't need the robot. They can do it laparoscopically very well. So, and why then to justify the robot for those surgeons that can do the D2 dissection without that? So to the point that either you do it robotically and I mean, just for the sake of discussion, I also favor hybrid approaches and if you to make this more complex, should you use the next generation? I mean, the other companies like the Google and Medtronic that use the disposable for Medtronic, and then you don't need specific instruments for the robot, or you like the intuitive, which costs very high in those or the Da Vinci for the robot for the staples, for example. So you can use either disposable, either the robot. So to decrease the amount of disposables, there is a lot of questions about a lot of variables. But if you use it well, as Dr. Silva said, measure the average direct. I think either use it all or nothing. That's obviously for the sake of discussion.
Excellent. Thank you all so much, and excellent presentation, Dr. Tova. We definitely look forward to seeing that article in JOGS, like I mentioned. I think you have some really big supporters here too, if you're interested in publishing this discussion tonight. Everyone, if you would like to be on our social media picture, please turn on your camera. And Dr. Tova, you can just unshare your screen. And then I'd like to thank so much to Dr. Weisel for being our moderator tonight and everyone that's able to join us. Our next talk will be on March 9th, and the topic is paraesophageal hiatal hernias. So same time, same place. And like I said, we'd love to have everyone. Okay, we're just going to take our picture on 3. 1, 2, 3. Excellent. Have a good night, everyone.
Great. Thank